Hello and welcome. I'm Dr. Fossel. What we're going to talk about today is the prospects for reversing human aging. And I mean that quite literally. There is an interesting poem written about 1300 years ago by one of the world's great poets, Li Bai. What he said was, if you only hunt for rabbits, then you'll never catch tigers and dragons. Most people, when they're dealing with aging, don't think you can actually affect the aging process or reverse aging, and they tend to go for symptoms and signs and biomarkers, that is, the rabbits, rather than looking for more fundamental issues, that is, the tigers and dragons. So we're going to talk about what we can do to actually reverse aging and age-related disease. And in starting this, I want to make reference to this comment by Stephen Hawking. It is the illusion of knowledge that gets in our way. It's the assumption that we already understand, for example, the aging process, that causes us not to ask the right questions and to make progress. Put a different way, there's this quote from Einstein: most people know things, but they don't understand them. And a classic example of this is the Vatican astronomers 500 years ago, who knew a great deal about the location of the planets in the night sky, but they knew nothing about orbital mechanics. They didn't understand orbital mechanics. And that was left to Galileo, Copernicus, and Kepler to make those sort of advances. So it's understanding that we need, not simply knowledge. It's not simply data, but it's understanding what the data actually means. And when it comes to age-related diseases, we tend to know a great deal and understand very little. For example, we have knowledge about biomarkers and hallmarks and signs and symptoms and clinical syndromes, but we don't understand the process of aging, and yet we think we do. We need to go a little further. I first became aware of this some 45 years ago when I was getting my PhD and MD and teaching the med school at Stanford. And what I realized is that most people felt that aging just happens. It's entropy, it's wear and tear, but they don't look more deeply and ask, why does it happen? How does it happen? What are the details of it? What's really going on at a more fundamental level? And I carried that same conversation with me to the NIH 25 years ago, and I gave the first talk ever on reversing human aging. And what I pointed out was that if we can truly get past our assumptions and our biases and understand the fundamental aging process at the cellular, genetic, and epigenetic levels, there's a potential for being able to intervene effectively in age-related diseases and cure and prevent them. And that was first expressed in the first book ever in this field, Reversing Human Aging, 25 years ago, and the first articles in the medical literature, which I wrote about the same time. And that culminated in the first and still only medical textbook on this with Oxford University Press, and then a more recent book for the general public, which is now out in 10 global editions. And really, one of the things that I'd like to note is that we have never done anything about aging itself, and it has to do with our lack of understanding of how it works. So we have certainly increased the mean human lifespan about threefold over the past 2 centuries. So people live longer, but aging itself has not been affected. We haven't affected the maximum human lifespan, for example. And the major reason that we've been able to increase the mean human lifespan and improve the quality of human life has been our knowledge of microbial disease. The most important things we've ever done in medicine do not involve incremental technical advances, such as robotic surgery or heart transplants or the latest statin drug. They involve conceptual advances, understanding how disease actually works. So rather than think that most diseases were caused by bad air or evil spirits or curses or original sin, we finally began to realize that invisible things, little microbes like viruses, bacteria, chlamydial organisms, fungi, and so on, can actually cause disease. So microbial theory was a huge advance. It allows us to have things like immunizations, vaccinations, the very first antibiotics like sulfa drugs and penicillin. Also simple things like hand washing that drastically lowered the maternal and neonatal death rates. Likewise, sterile surgery. Not only did this increase the length of human lives and improve the quality of human lives, it actually lowered the cost of medical care. Example, in 1950, prior to the first polio vaccine, most of the countries were involved with the endemic or epidemic polio were concerned about the cost of medical care because of the cost of iron lungs, the cost of nursing care, pulmonary nursing, rehabilitation, braces, and there were estimates that most countries would be medically bankrupt by the year 2000, at which point, though, the World Health Organization in the year 2000 found that the cost of treating polio was less than 10 cents per capita. Now, the reason is not because we improved the iron lung. It's because we understood microbial disease, and first the Salk vaccine, then the Sabin vaccine allowed us to prevent polio in the first place. Well, I think the same thing is about to occur as we understand the aging process. If we fully understand the aging process fundamentally, then we can intervene effectively in preventing age-related diseases and curing them. And the outcome of this will not be an increase in medical care or medical cost. It will be an increase in medical care or more effective medical care, but at a lower cost. It'll allow us to actually lower the cost of medical care personally and nationally and globally. Because rather than spending $1,000 or $100,000 a year on the last year of life with Alzheimer's patients, we can spend an estimated $5,000 to prevent or cure Alzheimer's in the first place. A very big savings. So yes, I think that we can improve lives, extend lives, and lower the cost of medical care. One of the things that has always frustrated people in regard to age-related diseases of the central nervous system have been these sort of remarks. As researchers say, everything works in mice, but nothing works in humans. As investors say, Alzheimer's is the graveyard of companies, which is accurate. In fact, when we say that everything works in mice, it's not just a problem with mice. We find the same sort of thing when we go translational studies from dogs, cats, baboons, rhesus monkeys, and so on. You find that it's very hard to take these animal studies and translate them into effective human interventions for age-related diseases like Alzheimer's. And when we say nothing works in humans, let me give you an example of that. This is taken from the clinicaltrials.gov website. We're looking at interventional trials for Alzheimer's. And as of the 14th of December this year, there have been more than 2,200 trials. And the global consensus is, and aducanumab notwithstanding, that we have not shown any ability to alter the course of Alzheimer's disease. So nothing works in humans. Where we are with regard to Alzheimer's, for example, monoclonal antibody therapy is about the same. We found a number of drugs that theoretically don't work, a number that are in the pipeline, and we have at least one, aducanumab, or Aduhelm here, that was released by the FDA in June of 2021. But when you look at the data, what you see is that there's this temporal step-off, a delay, if you will, of the symptoms for 6 to 8 months in the nursing home, but that the disease course then parallels that of placebo, which is what I predicted. So what you're finding is that you haven't actually altered the course of the disease, you've just postponed it or prolonged it slightly. And not only at the human cost and the financial cost of doing that, but you've increased the medical adverse reactions, or 40% ARIA reactions in many of these patients. What we prefer is not that. What we prefer to do is stabilize the disease, that is, prevent it from going downhill, and if possible, actually improve cognitive status in Alzheimer's without any adverse reactions. And I think we can do exactly that if we understand the aging process. The problem that we've had to date is that we tend to dig in the wrong place. We go after signs and symptoms or biomarker targets like beta amyloid rather than fundamental processes that underlie these diseases. And when that's true, it really doesn't matter how deep or how hard you dig or how much money you put into it. So whether you increase the NIH budget or whether you spend, as Biogen did, approximately $1 billion on aducanumab, that's digging in the wrong place. When that happens, it's not a matter of how hard you work, how many people you work on it, how much money you put into it. If you're digging in the wrong place, then digging deeper simply doesn't help. With that in mind, I was asked to write this paper about 2 years ago now, a unified model of essentially age-related neurodegenerative diseases. And what I was talking about were fundamental processes, a unified systems model that explains not only fundamental processes of neurodegenerative diseases, but age-related diseases in general. The first thing to think about is cell aging itself and the impact it has on these diseases and how it takes us from underlying risk factors to the biomarkers and downstream outcomes. So when I talk about a unified systems model, first let me tell you a little bit about what I mean by a unified model. What I'm getting at is that we have a lot of upstream risk factors, genetic risk factors, exposure to toxins, microbial diseases that we've had, for example, viral encephalitis, hypertension, hyperglycemia, history of trauma, head trauma, for example, closed head injuries, a lot of upstream risk factors, and we have a lot of downstream biomarkers of these diseases, these CNS diseases. But that between those is a fundamental process, sort of a stage on which all this plays out. So the fundamental process is the same, and the clinical outcome depends on where you start, whether you start with two APOE4 alleles or two APOE2 alleles, whether you start with a history of head trauma or a history of exposure to paraquat or dioxin, whether you have a history of hypertension. Those all have an impact downstream on what comes out for clinical syndromes. Now, when I say unified process, I also mean that clinically. So if we look at CNS diseases like the dementias, you find that while there are pure syndromes, Alzheimer's, Parkinson's, and so on, many of our patients overlap. So many patients I know who have Alzheimer's also have motor deficits. Many of the patients I know with Parkinson's also have cognitive problems. Many of these patients at autopsy will be shown to have vascular dementias as well. So there's a growing understanding that many of these syndromes, these age-related dementias, share other factors as well. There are some overlapping gray zones, some poorly defined borders between some of these, otherwise admittedly all too real clinical syndromes. In fact, there are atypical syndromes and mixed syndromes when you look at real human patients. And that's led some people to begin to suspect that there is this common fundamental shared process going on, in this case, age-related neurodegenerative disease. And the clinical outcome depends on your starting point. Start with one set of genes or one set of behavioral histories, you end up with one set of clinical outcomes. Start with another behavioral history, for example, smoking, trauma, alcoholism, different genetic histories, different epigenetic histories. You'll end up with different clinical syndromes, for example, Alzheimer's or Parkinson's. The same is true of age-related cardiovascular disease, another area which I'm writing a paper on for the same purpose right now. There are such things as patients with solely a myocardial infarction, some with just CHF or cerebrovascular accident that is stroke, capillary pruning, and so on. But when you look at all of the patients that we see clinically, what you find is that many of these patients have mixed syndromes. They have many of these things altogether, or they have slightly atypical presentations, suggesting again that what you start with in terms of your genes and your behavioral history determines what you end with, but that there's an underlying common stage on which these play out, and that stage is age-related diseases. Cell aging is the fundamental process which takes us from risk factors upstream, downstream biomarkers. And that's true whether we're looking at cells of the central nervous system, neurons, astrocytes, microglia, whether we're looking at vascular endothelial cells in the coronary arteries, chondrocytes, osteocytes, renal podocytes in chronic renal failure, leukocytes in immune senescence, skin cells or pneumocytes in the lungs. All of these play out on the stage of cell aging. Now, that's what I meant by unified, but when I talk about systems, it's something also subtle and important. This is an example of an engineering system versus components. So what you're looking at is an Airbus 380 cockpit, a Pro 15 Rolls-Royce jet engine, which is powered by that Trent 900 turbofan, and that's one of the fan blades. Now, when a fan blade fails, it's not an individual component that fails. It fails in the context of the system, in the gestalt. So if that fan blade fails, the question is not just what's wrong with the fan blade, but what's wrong with the fan blade as it's rotating in that turbofan, as it's powering that Pro 15 jet engine, as it's helping to power the flight of that Airbus 380 at 35,000 feet going hundreds of miles an hour at a high RPM and high temperature. In short, it is not simply a matter of the piece, the component, the biomarker, the hallmark, or the sign, or the symptom. It's a matter of the entire system and how it operates. The same is true medically. So, for example, these are typical signs and symptoms, biomarkers of COVID. But when you think about it, you realize those aren't COVID. They are outcomes of COVID. COVID itself is a viral infection that has an interaction between the virus and human immune system and other organ systems in our body, with the outcome being these sort of signs and symptoms, biomarkers. Biomarkers are not the system. Biomarkers are not the disease. They are important. We have to understand them, but we have to go beyond just knowing to understanding how these things work. And the same is true of aging. Here are typical macroscopic biomarkers of aging, but they are not by themselves aging. They are outcomes of aging, but they don't define the process itself, the system itself. At the microscopic level, the same thing. Aging is not simply a matter of, for example, telomere shortening or declining ratios of ATP to free radicals or declining DNA repair and so on. These are not aging. They are biomarkers, microscopic biomarkers of aging at a very fine level, but they're not the process itself. They're simply components of it. The same is true if we look at the dementias, neurodegenerative diseases. All of these things are found, for example, failure of the blood-brain barrier, lymphatic changes, and so on. All of these are very typical of many of the age-related neurodegenerative diseases, but by themselves, they are not a dementia. They're an outcome dementia. They're a sign or a symptom, but they're not the process of it, and that's where we need to understand. The same is true when we look at it genetically. These diseases are not simply genetic. Genetics play a role in the input played out on the stage of cell aging, resulting in clinical syndromes. So, for example, we know that 2 APOE4 alleles will increase your risk of Alzheimer's, but why? And why is it that any of these genes have a role? As you'll see, pointing to the genes is not sufficient to understand the process. This is a quote from a friend of mine. This is Dr. Len Hayflick, who first described cell aging 60 years ago this year. And as he points out here, almost all of us understand that the single greatest risk factor for age-related disease, like Alzheimer's, is aging. But then we totally ignore the aging process and we focus on the biomarkers, the histology, the physiology, the MRI results, the chemical results, the proteomes. We look at everything except the underlying process. We look at the outcomes, the biomarkers, the hallmarks, the components, rather than focusing on the central process. And if we really want to be able to intervene effectively in aging, we need to understand it. It is not enough simply to know We need to understand aging. With that in mind, let me introduce you to a couple of species that most of you know. Human beings, for example, typically live about 3/4 of a century on an average. Gorillas, that's Coco the gorilla. I was her babysitter for a year at Stanford. She had a bigger vocabulary in sign language than I did or do. She died at about age 40, and I will miss her. Typical for great ape. If we're looking at domestic animals, you're typically looking at 10 or 20 years, depending on the breed and the species. If you're looking at laboratory rodents, you're typically looking at 2 or 3 years, again, depending on breed or species. Well, you certainly can't say aging is just entropy without having to qualify it and say entropy that apparently has a difference in different species. Species age at different rates. And it's all well and good to say, well, they have genetic differences, which they do. Example, that mouse in the lower right corner has a lifespan that's about 40 times shorter than mine, and it only shares about 75% of the protein expressing genes. So presumably that lifespan difference has something to do with the other 25% and the regulatory genes that results in a different lifespan. But why? What is the difference? How does it play out? It's also not enough, even if we focus on a single species and a single gene. So these are children, 30 of them, that I'd gathered together about 2 decades ago, and every year we'd gather them together. These children have Hutchinson-Gilford progeria. They have an average lifespan of 12.7 years. This year we had taken them for a tour of the White House. We're on the North Portico here. And every child in this picture is now long dead. They die overwhelmingly of cardiovascular disease, for example, strokes and heart attacks. They also have osteoporosis, osteoarthritis, balding, thin skin, typical features of aging. Well, we think we know the gene involved. It's the lamin A gene. But note that that doesn't tell you what it does. It doesn't tell you why that causes an average age or an average rate of aging that's easily 4 or 5 times mine. Why did they age so fast? So simply pointing to a gene is not enough. You need to understand what's going on. Furthermore, aging is not itself ubiquitous. There are examples where things, at least retrospectively, show no evidence of aging. So every cell in your body derives from a fertilized ovum. That ovum was inherited from your mother, and when you inherited, it was a perfectly functional cell with no evidence of aging. But the provenance of that cell goes back 4.5 billion years. That cell was literally 4.5 billion years old, and in retrospect, it was delivered to you as a perfectly healthy, non-aged cell. So why is it that most of your somatic cells demonstrate aging over the past few decades? Many people would like to point to mitochondria, but the same problem occurs. Every mitochondria you have derived from healthy mitochondria you inherited from your mother, and that provenance goes back again, almost 2 billion years, depending on who's making the estimate. So you inherited perfectly adequate cells and mitochondria with no particular evidence of aging at fertilization, and yet now you show cellular aging. So why does aging occur in some cases and not in others? Now, why does it occur at different rates in different children and in different species? Well, aging itself is not simply a matter of wear and tear. It is not entropy. It is entropy in the face of maintenance. So if I'm looking at the germ cell lineage, what you find is that maintenance is essentially flawless retrospectively. If I look at your typical cells, you find that maintenance begins to show subtle defects. So for example, if I'm looking at the cells of the 80-year-old man in the wheelchair on the left, what you find is whether I'm looking at the fibroblasts, the keratinocytes, the macrophages, the vascular endothelial cells, the microglia, the pneumocytes, you see subtle changes in maintenance that allow entropy to take over. You might in fact say it's a matter of having to run in one place as fast as you can to keep up, in line with Lewis Carroll's quote from the Red Queen. Your cells have to maintain themselves effectively, just as the germ cell lineage has, otherwise they begin to undergo age-related changes. If you look at molecular pools, what you find is that this is exactly what's happening. Whether I'm looking at some of the molecules between cells, for example, collagen and elastin in my skin, beta amyloid around my microglia, or cytochrome C oxidase, or superoxide dismutase, whatever I'm looking at within my cells or between my cells, you find molecular turnover is occurring. That is, there's almost no molecular pool in the body that is static. You don't produce it at birth and then it stays that way. Rather, you're continually producing and degrading, producing and degrading. It's a recycling phenomenon. And in young cells, what you find is that's a very rapid rate of turnover. So any damage, which is signified here by the little red star, is very minimal. But as you get older, the rate of turnover, the rate of molecular recycling in any molecular pool we look at slows down to the point where you begin to get a higher and higher percentage of dysfunctional molecules, which results in a higher and higher percentage of dysfunctional cells. You can even look at this mathematically. This is taken from my Oxford University Press textbook. And really what it says is, if young cells have a high rate of turnover, they don't have much damage. If older cells have a lower rate of turnover, they have much more damage that they accrue over time. We can actually look at this in particular examples. So we're going to look at this in terms of CNS aging, in this case, Alzheimer's dementia, and we're going to look at the particular case of beta amyloid. And what you see again is that in young cells, microglia, for example, they're continually making beta amyloid, secreting it, binding it, internalizing it, degrading it, making it, secreting it, and so on. It's a continual recycling process. In young cells, it's fairly rapid, and the result is, even when some of these molecules become denatured, damaged, oxidized, you don't get much in the way of accrued damage. However, as we get older, that rate of molecular turnover of beta amyloid goes down, and the result is you begin to get beta amyloid microaggregates as we get older. It also depends on the genetic starting point of the patient. So it's not simply a matter of getting older, it's getting older in the face of a different genetic starting point. If you're lucky and you have two ApoE2 alleles, you tend to make beta amyloid that's not very sticky, so it doesn't tend to accrue a lot of damage between the cells. So even as you begin to get older, for example, in your 40s and 50s, you may be turning down your rate of beta amyloid turnover, but you don't tend to have much in the way of microaggregates. Now, if you're unlucky, on the other hand, and what you have is two ApoE4 alleles, what you find is you make stickier molecules. The result is you get more and more damage externally, even at a relatively younger age. So you can get patients with two ApoE4 alleles who may be having many more beta amyloid microaggregates, even at age 20, 30, or 40. Whereas if you're lucky and have good alleles, you may not be accruing much that's significant, even into your 80s or 90s. But in any case, as we get older, that rate continues to go downhill. And depending on your genetic starting point and behavioral history, what you find is you begin to accumulate beta amyloid plaques, with the result being functional dementia. That is the clinical syndromes we talk about. And this is true whether you're looking at beta amyloid or whether you're looking at tau tangles, mitochondrial dysfunction, as we'll see in a minute, inflammatory changes, microglial activation, all of the things we can measure. I'll give you an example of this. Looking at cell aging, what you find is that as the cells age, as telomeres shorten, as the pattern of gene expression changes, and as the turnover of molecular pools change, it has an effect, for example, on mitochondrial dysfunction. About 99% of the aerobic enzymes in your mitochondria are produced in the cell, that is, they're coded for in the genes in the cell. And as that slows down, molecular turnover slows down, you begin to have more and more dysfunctional aerobic enzymes, for example, cytochrome C oxidase. And the result of that is, over time, your ratio of production of ATP to free radicals, reactive oxygen species, goes down. You become a much more inefficient mitochondria. You make less energy, you create more free radicals. Furthermore, the membranes are also being turned over. The lipid molecules in those membranes are being turned over more slowly, so the membranes become more porous. Furthermore, the scavenging molecules like superoxide dismutase and catalase are also being turned over more slowly. So not only do you make more free radicals, do they escape the mitochondria in the cytoplasm and ultimately into the nucleus as well, you don't scavenge them as well, and when they create damage, you don't recycle other damaged molecules as fast. So for 4 separate reasons, there's an exponential decrease in mitochondrial function as we get older. And as I say, a lot of these free radicals will escape on into the nucleus. What about cell aging and DNA damage? There are 4 separate major families of DNA repair enzymes. And what you find is that all 4 of these show decrements in the rate of recycling. So your ability to detect, excise, replace, and ligate into place the damaged DNA that you're incurring now as you're talking to me over the past 23 minutes has already gone down as we get older. And the result is you begin to get this very subtle but exponential increase in the rate of cancer. So cancer is not simply a matter of lifetime exposure to carcinogens, but lifetime decrease in your ability to repair DNA damage effectively and efficiently. So overall, what you're seeing then is a number of upstream risk factors that have an impact on the rate of cell aging and the kind of cell aging you undergo, with downstream outcomes clinically, as well as the biomarkers. Now, the question that comes up practically is not just what's going on with aging, but where can we intervene? For centuries, but certainly over the past 100 years, we have tried to intervene more effectively in upstream risk factors. For example, decrease your risk of trauma, control your hypertension, try to guarantee euglycemia, try to avoid toxin exposures, try to avoid infections, for example, again, encephalitis, and those will lower your risk and delay the onset of age-related diseases. And likewise, more recently, we've tried to intervene downstream, for example, with beta amyloid plaque and the monoclonal antibodies I just mentioned. But none of these have ever been shown to stop, let alone reverse, the aging process at the cyto level or otherwise. Can we do better than that? Well, the answer is yes, we can, and it's already been done. This is a paper by Andrea Bodnar some 23 years ago in Science, And what she showed is that you can actually reset cell aging in human cells in the laboratory. Using telomerase, you can not only change the histology, the morphology, the physiology of the cells, but you can reset the pattern of gene expression signified here from that of an old cell to a young cell by using nothing more than telomerase to re-extend telomeres. The same thing is true of human tissues. This is a paper by Walter Funk 21 years ago. And what he showed is that you can actually literally grow young human skin from old human skin cells, again, if you use telomerase. The same thing is true not only of skin, but of osteocytes. The same thing is true of vascular endothelial cells. So we have known now for 20 years that we can reverse aging in vitro and ex vivo using human tissues. The question is, can we do that with the whole organism or human patients? Well, the first paper that looked at that was important was about 11 years ago by Ron DePinto. And what he used as a way of changing, or putting in a switch in the germ cell lineage, and then be able to turn on and off telomerase in, say, the F4, F5 generation, which doesn't help us clinically. But a more important paper was that of Maria Blasco, who's the director of CNIO. And what she showed is that you could use a common approach, that is an AAV9 vector, in this case a mouse TERT gene, to reset telomere lengths in middle-aged and older mice, with the outcome that you normalize their behavior, they become younger in terms of behavior, as well as their physiology, in this case bone mineral density, subcutaneous fat, immune function, and so on, as well as demonstrating an increased lifespan. So we know that we can, at least partially, reset aging or reverse aging in the organism, and the question is, can we do that in human beings? Well, let me summarize where we stand. We know that cell aging is the central mechanism, and it's probably the optimal point of intervention. We know this is a platform therapy. That is, it should be equally effective for CNS diseases as for cardiovascular diseases, osteoarthritis, osteoporosis, chronic renal failure, immune senescence, wrinkles. The question is, can we take that to clinical human trials? We also know that the cell aging model accounts for all the known risk factors upstream, all the known downstream biomarkers, and it accounts for clinical heterogeneity. Why do I get Alzheimer's? You get Parkinson's. Why do mice have one form of behavioral decline, dogs another, and humans a third? It accounts for that. It also is consistent with all of the known clinical and research data on aging, and it's predictively valid. For example, it predicted the Eli Lilly solanezumab data, the Biogen anakinumab data, and other clinical trials. Furthermore, it offers not only a novel target, but one that is technically feasible. We can do this now in human trials, and it's been shown to work already in vitro, ex vivo, and in vivo in mice. So what we're going to do is take this to human trials and demonstrate that we can literally reverse aging. Our major focus is going to be credibility, because this is something many people will not believe because they don't understand aging. We're then going to demonstrate that it's effective, safe, and we can try to do this at a low cost and as soon as we reasonably can. So let me ask two questions to summarize all of this. First of all, can we reverse aging at the cell and tissue levels? And the answer is yes. That was first done 20 years ago. The second is, can we reverse aging in human clinical trials and thereby cure and prevent human diseases? And the answer is yes, we probably can. The data suggests that we can and that we soon will. I appreciate your listening. I hope you found this interesting, and we'll take it to human trials and we'll see what happens. Thank you very much for joining me. I appreciate it, and I wish you a good day.